Welcome to the webinar, Analog Accuracy, when traditional impressions are clinically required. This lecture will be presented by our very own Tremaine Watkins, CDT, and we're going to begin shortly. And with that, it is my pleasure to welcome back virtually Tremaine Watkins, CDT. He is the NDX Director of Strategic Education. Tremaine has been working in the dental laboratory industry for more than 35 years. He has extensive experience in fabricating analog and digital prosthetics, with experience in implant-supported and retained restorations. A respected lecturer on both laboratory and clinical aspects of restorative dentistry, Tremaine trains technicians and provides clinical support in case planning, troubleshooting, and implant placement. And tonight I learned he's also a beta tester. So with that, I get to say, welcome back, Tremaine. We're looking forward to this course.
All right. Thank you very much, Jessica. Thank you, everybody, for joining in. Yeah, Jessica and I were talking about this before we got going. And according to the latest study from JDT, the Journal of Dental Technology, 57% of the cases coming in are still using analog impressions. So let's talk about this. Hopefully, I doubt that everything that we're going to cover tonight will be news to you, but I hope that everybody gets a pearl or two that'll help tomorrow in your practice. So we're going to start out by talking about physical impressions. We'll talk about materials, and then we'll talk about techniques, potential problems impressing crown and bridge, removable implants. We'll talk a little bit about full arch at the end as well. So I have my own housekeeping stuff. I am a full-time employee of National Dentex Corporation. I was paid to create this presentation. Other than that, there's been no financial support for this presentation, so anything that I talk about is what I think would be helpful. So tonight we're going to look at situations in which you might want to use a traditional impression. I want to talk about appropriate materials and techniques, especially for fixed, removable, and implants. And then we want to look at some common challenges and kind of decide how we deal with them, and specifically if we need to take another impression or if we can maybe make it work. These are some resources that I've looked at that I find helpful, and you might as well. So I love history, so I'm going to start out with a little bit of history. Interestingly, the first recorded use of dental impressions in the United States was a dentist in New York who was advertising in 1787 that he was using beeswax. And so he was using this, my apologies, for cases where the patient could come and he do direct dentistry, interestingly. He was borrowing a technique that had been developed in Paris 25 years before. So a fairly, in the course of human history, a fairly recent phenomena. So the first steps in, I would not call that a modern impression material. So reversible hydrocolloids developed in the 30s. And interestingly, you still see those in partial duplication. So for all of you that have been in a laboratory and seen that greenish blue liquid that pours out of the big machine, that's the reversible hydrocolloid. Still makes an awesome duplicate. Not so fun to use in the mouth. Fun fact, I've actually poured models from irreversible hydrocolloid for crown and bridge cases many, many years ago. So, man, that stuff's slimy. Alginate in 1947 was really the first the advent of something that we're still using today, basically. Polysulfides came along in the 50s. I have a picture in here of a polysulfide impression. Man, does that stuff smell bad. I'm guessing that patients didn't really like that. And then condensation cured silicones were kind of the first of the modern materials, still not as stable as we needed. Some of the things we're still using today, polyethers came out in 1965, and they're still very, very good. They have good mechanical strength and elastic recovery, virtually no shrinkage, and they're hydrophilic, which is really nice. They tend to be a little bit rigid, as you know, and the mixing equipment for them is fairly expensive. We see them in the laboratory every day, but not as much as VPS. VPS has kind of taken the world by storm. I think that probably the vast majority of dentistry today is being done with two-part vinyl polysiloxane. What's cool about them is they're very highly dimensionally stable over time. They're almost impossible to distort, really good elastic recovery. Interesting, VPES, I haven't heard much about it anymore. I think it kind of came out at the wrong time. Somebody thought, well, let's take the hydrophilic nature of polyethers and combine it with all the other good stuff from VPS. And they're still being sold, and I think it's a good material, but it kind of was a new and cool impression material when digital was coming along. So speaking of digital, you might ask, why are we even talking about physical impressions in 2026 when we can do everything digital? So besides the fact that some offices don't have intraoral scanning yet, let's talk about situations where you have an intraoral scanner, but you might need to use a physical impression material anyhow. One of the analogies I like to use for dentistry is a toolbox. The more tools I have in my toolbox, the more capable I am of dealing with the odd situations that come up. So let's think of some examples. If we have a subgingival margin with lots of fluids, that's going to be extremely difficult to scan. A lot of times what happens is the scanner scans the top of the pool rather than the depth of things, and then you wind up with short margins. Physical impression materials are nice because, especially if they're a little bit thicker, they can actually displace some of that fluid and get a little bit better capture. Removable cases. We're seeing a lot more with the current generation of iOS. We're seeing a lot more capability of scanning large sections of soft tissue, denture cases, and stuff like that. But the premier workflow for digital dentures today is a reference denture. So you have to take a reline impression with impression material to get a good result. And then for full arch, there are some great, for those of you that are familiar with the horizontal scan body systems, there are some really neat technologies coming out for doing full arch scanning. But again, you got to have the right kind of scan bodies, which aren't free. And you have to have a current generation scanner to get the best result. So sometimes folks are still using open tray impressions and verification jigs and the thing. It's still a great, effective workflow. Digital is just a little bit faster. So let's talk about what does a good impression look like? And these are kind of the standards that we'll need to apply to all the different things that we'll be impressing. So the first thing is mix. We need the impression material dispensed in the perfect proportions and completely mixed. So if we're using an auto mix gun, most of the time what's involved is just making sure both materials come through and expressing a little bit onto a paper towel or your glove or something before you start taking the impression. But if you're using some of the polyethers have a hand mix component, so if you're hand mixing, it's got to be perfectly mixed. And even if we're using like alginate or something like that, we need to make sure we don't just slap some water in there, but that we mix. If we want an accurate result, we need to use the appropriate amount of components. Last but not least, we want to make sure that when we're using a four-handed technique like this impression with a wash and a base material, we want to make sure that the wash and base have the same set. In other words, we don't want to use a slow set base with a fast set wash or vice versa. And it's better if they're the same brand. And then when we're working, the person who's usually the dentist who's doing the wash material and the assistant who's filling the tray should start at the exact same time. So that way the chemical reactions happen when they're supposed to get better cross linkage and just a nicer impression. One of the scary things about impressions is that they can look awesome and not be, as I'm sure all of you have run into that. So as we manage these variables, we can, as much as possible, eliminate the cases where you get an impression like this and you're like, this is the best impression I've ever taken, And then when you try to put in the restoration, it doesn't fit. Impression tray, so important. When you're doing a physical impression, if you think of your impression as a house, the tray is the foundation. It's got to be large enough to seat passively, but small enough to where it holds the impression material around the teeth, kind of forcing them in to get good adaptation. We need to make sure that, like in this area, we want to make sure that the tray doesn't contact the ridge too firmly, or else the person can push on this and then create a elastic preload that then springs back, causing distortion. We need to make sure that the tray is fully filled and that and that the impression material adheres to it. So sometimes that's mechanical retention. Sometimes we're going to put a little bit of adhesive on there. But the tray is so important, using the right tray and using it well. We want to look at details. So one of the things that's a telltale that we've got a problem is when we don't see just a little texture in there. If you see an area that looks smooth, be a little bit suspicious. That could well be not adapted properly and therefore not dimensionally accurate. And then we want to think about adaptation. Of course, we think of like this, adaptation to the preparation, which is really good in this case. We also want adaptation between the wash and the base. We don't want to see like a line here or something like that, because that something is inaccurate if this hasn't flowed out perfectly. We also want to see, you'll see an impression later on where there's a gap between the tray and the impression material. And we don't want to see that. We want really good adaptation between the impression and the tray so that the tray can do its job and support the impression. So again, we're not going to repeat these every time, but as we're talking about fixed, removable, implants, whatever, all of these things need to be present on every physical impression that we take. So let's start out by talking about fixed restoration. Since we take more of those than anything else, we'll talk about that. We'll talk about best practices for taking the impression, and then we'll go through some troubleshooting. Tray selection. We want to make sure the tray is well adapted to the mouth, but not so tight that it limits the flow of the impression material. When you're trying in the triple tray, kind of hold the patient's cheeks back and make sure that they're not biting on that strap that goes across in the posterior, because that will make even the best looking impression inaccurate. I love these metal trays. I know they're a pain to sterilize. Not too many people use them anymore, but you want to talk about a foundation. There's a sturdy foundation for an impression right there. Oh, I have a question. So let me go backwards here just a little bit. Does using a longer set time improve the impression detail and accuracy? I would say it depends on the case. So if you're doing a small case, like a number 14 prep or something like that, I would say no, because it's going to give the patient more time to move and potentially generate inaccuracy. But if you're doing a full mouth impression or something like that, where it just takes time to syringe around all the margins, then the slower set will help you, because you have to get the tray in the mouth by the time the working time expires. So I feel like that would be how I would decide. If I needed the longer working time to get the tray in, I'd use a longer set. Otherwise, I'd probably use a faster set just so the patient is less likely to move. Good question. Thank you very much. Okay, I'll get back on track here. Other thing is, you guys know about this, latex gloves can inhibit the setting of VPS. We'll talk about some of the problems that can happen with VPS, and quite a few of them are related to latex contamination. So the next thing we want to talk about is retraction and fluid control. One of the things that's challenging in the laboratory is that when you look in the mouth, you're like, oh, well, that's pink and that's white. Okay, well, I can see that. It's clear. When we make our models, because obviously from a physical impression, we're going to be making a model, but even in digital cases, everything is kind of the same color. And even with color scans, a lot of times you have blood staining. So it's very difficult to see, oh, this is tooth and this is gingiva. So I think one of the goals that we need to have to get really nice margins is that you need to be able to see past the margin a gap between the margin and the tissue. Now, I know that there's been many, many studies that say that dentists like one cord, labs like two cords, and potential recession can occur with a double cord technique. So you kind of have to decide what you can get away with in your practice, but make sure that there's a visible gap at the margin, because that's going to make your fit so much better. That's how you'll get those sweet x-rays where you see the margin just blend perfectly to the tooth. The syringeable retraction materials like Expasil and Traxident, those can work great in some cases. You just want to make sure that you give them enough time to work. Pace usually require about 2 minutes, and your traditional cord will require sometimes as much as 3 to 5. Keep in mind that if you're using double cord, when you pull the first one to take the impression, you have 30 seconds. Another good question. Will a custom tray give better detail and adaptation for a full arch impression for fixed pros? I would say usually, especially if you take a good preliminary impression, because then we're going to get nice adaptation. And I think that really the hidden benefit of custom trays is that the thickness of the impression material over whatever you're impressing is very uniform. So you're going to tend to get less distortion from big areas of impression material and small areas of impression material during polymerization. And you're also going to get better hydraulic pressure forcing the material onto the tooth. So I would say yes, it would be helpful. I like to use lower tray for final impression on upper. Also, it's shaped like a custom tray. It saves a ton of material on the palatal. I've seen that done quite a bit, and I think it's a good trick. The only thing I'm concerned about is sometimes depends on the tray. Some lower trays have kind of a little wing on the lingual side that's designed to pick up the mylohyoid ridge, and those can interfere with seating on the palate. So if you trim them off, it's fine. If you have one that's a little more symmetric, then that could work well. I think that's a good idea. You want to make sure, especially when your staff's helping you out, that if you're doing something that needs a palate, like like maybe you're doing a full arch case and you want to have a palate for indexing for the bite, or if you're doing, of course, if you're doing removable, can't do that. But yeah, that can be a good trick, and especially good for gaggers. I really like that. Thanks for sharing that. All right, so anyhow, but just keep in mind that once you pull that top cord, you got 30 seconds. So make sure you have all your materials ready to go. And then, of course, we need good fluid control. Some of the pre-preg hemostatic agents can be helpful for that. And, but you want to make sure that your sulcus is nice and dry and you have your bleeding under control. And I would say you want to do that first before you pull the cord, because you want to make sure everything's ready to go, pull the cord, take the impression. Timing and gagging. I feel like timing is something that is sometimes overlooked. Again, like we talked about, when you're doing a four-handed technique, you want to make sure that I've seen offices that say 3, 2, 1, go, and they both start expressing the material at the same time. You want to make sure, again, that you're using matched materials. And then you want to make sure that most of your impression materials are going to have a working time and a set time. You want to make sure that it's in the mouth, stable, not moving by the end of the working time, and then just hold the time for setting. Check your expiration dates and watch your temperatures. Most impression materials have a specific temperature. And I mean, most of us are storing stuff in our office that are temperature controlled. But if you have outside storage or something like that, kind of keep that in mind. Probably impression material isn't the best stuff. Store that inside. Store your Dystone outside. One of the other tricks that I think would be really helpful is when you're syringing your material on the prep and the contacts, take a little bit of air and blow it down a lot of people don't do that, and it just gets you so much better adaptation. I think you'll find that that little bit of impression material that goes past the margins, when you start using that blowdown technique, you'll see that all the time. And it really, again, it helps us in the laboratory because we're like, okay, there's the margin. So we can see that clear margin and get you a much better fit. I put the egg timer in just for fun. I realize we're all using our phones these days, but if it's 4 minutes, it's 4 minutes. It's not 3.5 minutes. Because what happens when we pull the impression material early is that we haven't allowed the chemical reactions to get finished. So again, even if it looks good, there's a chance of having dimensional instability. Of course, you guys all know who your gaggers are, and I'm sure you all have strategies. One thing that can be helpful is having them sit up. And don't forget the power of distraction. If you can give them some kind of job to do, hey, tell them, hey, why don't you wiggle your toes while you're doing this or whatever? That can be a good idea. Also, intraoral scanning can be helpful. And that trick of doing the mandibular tray on the maxilla, another good one. So impressions for fixed, in other words, like how big of an impression do you need? You know how us labs are. We're always like, oh, I want a full arch for both. And that can be good. The one thing we do find sometimes is like, let's say you're doing number 3. A lot of times, for whatever reason, the impression seems to get a little bit distorted on number 14 sometimes. And we can actually see situations where it's canting the bite a little bit. So that's something to keep in mind. However, anytime we're doing a case in the aesthetic zone, and the aesthetic zone, as you know, varies by patient, but we want to make sure that you always capture the contralateral tooth. Like if you're sitting in a case for 6, you really can't do a quadrant through 8 or 9. Your laboratory, if they're going to do a decent job cosmetically, they have to be able to see number 11. Now, if you take a study impression and send it in, that's fine too. But make sure that for any aesthetic case that the contralateral tooth is visible so your laboratory can do a nicer job. And here's what's funny. So you're like, well, you're a technician, so of course you're going to ask for big impressions. But I'm going to surprise you here. I'm going to ask for small bites. So one of the things that you'd be surprised when you go in the laboratory is we get these big old bites and we trim them down usually till it's just the preps and a little bit of the adjacent teeth. And you might ask, well, why are you doing that? The reason is that we want to be able to see how the teeth interdigitate. And the same trick will work for you guys clinically. So let's say you're doing this case and it's just a prep right here. Just syringe some material onto the prep and a little bit on the adjacent teeth, and then have the person bite together. That way you can actually see that they're closed nicely. So that's kind of a little trick, I think, many of that can make cases a little bit better. So large impressions, small bites. What are some of the problems that can happen with our impressions? Oh, look at this. Another good tip. Breathe through the nose and wiggle the toes. Sit up nice and straight. It says, severe, I'll use some chloroseptic spray. So there's a nice pearl. Thank you very much. Let's talk about some of the problems that can occur when you're taking an impression and how to avoid them and kind of how bad they are, basically. So here's one I've been beating on quite a bit, which is tray contact. And this is a triple tray. And you see how you can see the details of the tray here? That means the person was biting pretty hard on this. So what this had the effect of doing is making this wall and this wall of the impression tray spread when the bite was being applied. So as soon as the person releases, this and this compress. So now the teeth in the impression, they look pretty, but they're actually smaller than the person's mouth. So therefore, like if you were to make I don't know what you could make on this, abandoned loop, you try to put it down and it wouldn't seat. You'd be like, why doesn't this seat? It's because the tray contact led to distortion. Now, if this is a metal tray, single-sided metal tray, kind of who cares? You have to use your judgment and look at the case and say, was the case compressed in such a way that it would spring back or not? If you think it sprung back, I'd take another impression. Incomplete margin capture. So we're going to look at a couple different ways that you can see this. So what this is talking about is where that last little bit of impression material at the edge of the margin is kind of ripped off and it's all jagged looking. It could be caused by insufficient retraction or maybe by fluid contamination, but usually that looks a little bit smoother. Maybe we didn't get, obviously, maybe we didn't get the light body material injected all the way down into the sulcus, or a weak impression material that tore. Every once in a while, you'll get lucky. I mean, I've seen a lot of these in the laboratory where it tore right at the margin, since the margin's kind of a sharp line. If the margin's there, it's good. You don't have to get anything beyond the margin. But if you see the margin torn through, of course, the best your laboratory is going to do is extend to this line, so you wind up with a short ragged margin. So most of the time, this is a retake. So voids on the margin. Now this is different. So the last one was jagged. So you looked at it and you're like, man, this edge is really jagged. This is when it's really smooth. Like the impression didn't get down to the margin, but it's very smooth. So this is often either due to fluid or air down in the sulcus. It can also be that the material set too quickly. So in other words, maybe it was really, really hot in the room that day. Maybe you were a little bit slow getting the material in. If it didn't get in by the working time, that can lead to this. Again, if you got the margin, good, but if the margin's not there, it'd probably be good to take another impression. If a piece of cord stays attached to the impression, the question says here, if a piece of cord stays attached within the impression, do you recommend leaving it for evaluation and removal by the lab? I do. I like being able to do that. We do it quite a bit, and it lets us see. Sometimes the cord is right at the margin, and it lets us see when we take it off, okay, the margin's still there. If you want to do it, you certainly can, because you have the ability to retake it if it tears. But it is kind of nice to see the whole impression before we have to make any alterations. So that's my 2 cents on that. Thank you. And then tearing at the margin. So this is kind of the same as this, basically. This one here. So this is, the material got stuck, and when you pulled it, instead of tearing all the way away, it tore and left a little flap like this. And this can sometimes be caused by the impression material not setting up down the sulcus. So we'll talk about this a little bit. It could be a smear layer from provisionals or core buildup. Of course, latex can be a problem. So if it tears, same thing. If it tears apical margin, good. If not, you may need to take another impression. Okay. Would you prefer seeing the impression rather than the poured models? So usually, yes. One of the things that we have in the laboratory is, like, most of our labs have a thing called a smart box, and you fill up part of it with distilled water, fill it up with type 4 dye stone, and then you type in which kind of stone you're using, and you put your little container on there, puts the powder in by weight, puts the water in by weight, and we mix it. So it gives us the ability to totally control our ratios and make sure that our models are hard and that they also have the appropriate amount of expansion. So in general, we have better equipment for pouring. The exception would be things that don't travel well, alginate, hydrocolloid, that sort of thing. We'd prefer that you guys pour those up. What I would say in general, say models for dentures are the exception, but other than that, it might be good to have a little stash of dye stone. And when you're pouring things in the office, make sure you mix it nice and thick, pour it under vibration to get all those bubbles out, and use a dye stone so that way it's sturdy. Another little trick is there's no law that says you have to separate it. If you think the pour is good, leave in the impression and send it to us. That way the impression acts as kind of a shock absorber in transit. So that can be a good little trick. Irregular voids. We all have seen these. These happen all the time. So again, it could be that basically the material was partly set and just didn't flow in. Maybe the tray adaptation wasn't good enough, or maybe it was a little bit underfilled and it didn't get forced in there. And the problem with this is you have to decide if it's in a critical area. If this is on the distal of number 2 and we're doing a crown on number 5 and it doesn't affect the bite, kind of who cares? I'd send it. I wouldn't take a new one. But if if this is the impression of the prep on number 5, it'd probably be good to take another impression, but usually caused by setting. All right, this one is my pet peeve in life. You don't see this so much anymore, but years ago, there was somebody who said, I got a great idea. Let's take base material and take an impression of the prep. Then what we'll do is we'll prep it, reline it, and take another impression. So one of the effects of that was this, because obviously the two materials were set up at different times. But the bigger problem is that unless you're using a very, very sturdy tray, when you push that tray down, the base material balloons. And then, of course, same problem as everything else. When you release it, that springing force compresses your dies. That impression technique is notorious for making things fit tight. And of course, there were different model techniques and different stuff like that. But please, please help your laboratory and don't do that technique. It makes everything so unpredictable, and that's not what we want. We all want take an impression, send it to the lab, make the stuff, deliver it. That's what we want. So if you avoid doing this, it'll help. I wouldn't, and just as an aside, if you get this, always take a new impression, even if it looks pretty good, because you can assume that this problem is happening everywhere, even in the areas you can't see. And so the base material isn't supporting the wash. And the impression material not set up. This can be contamination from a variety of different things, kind of the stuff we were talking about with the tearing. Could be expired material, could be sometimes when the two materials don't syringe out evenly and we forget to express some. I had that happen to me one time in the laboratory when I was duplicating something. I was like, darn it. And it never did set up, so I had to redo it. If you see this, you always have to redo it. I mean, there's no point in sending this. So, all right, so removable impressions. Let's talk about that. Impressions for full dentures. So as much as possible, when we're doing our full denture impressions, we want a mucostatic impression. In other words, this is a fine point, but we want to put as little pressure on the tissue as possible while still getting an accurate registration. Because if you think about it, every area that we push on that's depressed, our prosthetic is going to push on it too. So border molding is a great way to do that. So this is an example where a custom tray, we were talking about this earlier, makes a huge difference. Firstly, because as you know, denture patients' mouths vary so much. Secondly, we can get a much more uniform material, which helps with our goal of being mucostatic. And then it gives us a good foundation for doing our border molding. So what we want to do is make sure that our borders are about 2 millimeters short of where you want them, and then paint the whole edge here with impression adhesive, inside and outside. Put your heavy body in, and then do your border molding. One of the things that you can do is takes 5 minutes for the adhesive to set up. You can have the patient practice. So for the maxilla, you want them to open and close their bite and then perform left and right excursive movements, and then pull their left cheek, right cheek, and upper lip down to help activate these muscles up here. For the mandible, you want the person to stick their tongue out first towards the right corner of the mouth, then the left, and say oh and suck in their cheeks. And then you want to pull up on the left and the right and the center. So one of the things that you can do is border molding is so important, because a lot of times when us laboratories are making dentures, what we'll do is we'll go just a little bit shorter than the impression. And if we know we have a border molded impression, all we have to do is process to the borders on the impression. So when you do your border molding, make sure you note on the prescription, impression has been border molded, duplicate. That's really important. So then paint this whole area with adhesive again, and then fill it in with Light body if you can get away with it, because again, the lighter the impression material, the less viscous it is, the less it's going to push on the tissue and get a better result. Yeah, that's a good idea. If you don't have a laboratory custom tray, one of the things you could do is use a larger stock tray, put putty material in it, and then squish that down in the person's mouth. The trick is you have to kind of overseat it a little bit because you need space to do your border molding, or you might need to trim it a little bit. But that's a great idea so that you can have the benefits of a custom tray utilizing a stock tray. Just make sure you leave enough material because you don't really want to burn through to the putty. You want a nice uniform thickness. When you're all done, except maybe at the edges here, because this kind of works like your stop, you'll want to see the light body material all over. Good trick. Thank you. Boy, we got a lot of good tricks today. It says, do you see a difference on results when comparing heavy body versus compound material? Not, I think both can be used well. It seems to me that heavy body is easier to use. Sometimes you need to use compound when your tray is really short and you're trying to extend it. But I think that you're going to get better adaptation easier with the heavy body. That'd be my 2 cents on that. Oh, listen to this. Here's a good tip. Exa Advanced it's a light body material, but it's medium viscosity. So it's going to be really nice for doing this second impression. So after you've done the heavy body or compound, if you like, to do your border molding, then this Exa Advanced will be more likely to stay in here and adapt to the tissue without pushing too hard on it. Thank you for the tip. That's great. All right. So you've done all that. You're looking at your denture impression. Here's my polyether, a blast from the past for some of us. So of course this is a monophase impression material, so there's no lines, but this is a beautiful denture impression. You can see how it has nice borders. We're capturing all the frena, and see how there's texture everywhere. That's one of the things you really want to be looking at, because if you don't have good texture, you probably don't have good adaptation. Partial dentures. Partial dentures, in my opinion, are probably the hardest thing to impress because you have to take a crown and bridge accuracy impression on all the teeth, and you have to pick up all the tissue. Now, if you're doing, let's say that these teeth were missing back here and you were doing the large saddle in this area, you might benefit from doing partial border molding in this area because it's going to be primarily mucostatic anyhow. But yeah, picking the right impression material, getting a good tray is going to make a huge difference on these. Because if you think about it, it's a bridge that fits on all the teeth. Now, little secret, intraoral scanning works great for partials because you can take crown and bridge accuracy on anything you can take a picture of. So I really like intraoral scanning for partials. Because it just, and you have enough teeth to where it's easier to scan than if you're trying to scan a denture. So for what it's worth. One of the other things you got to watch out for with this is making sure you get the tray in and hold it. It's better to hold it yourself kind of in the premolar position instead of letting the patient bite on it. So that way they're less likely to move a little bit when it's setting and create those flow lines and all that stuff. This is a beautiful impression, by the way. If you get an impression like this, your laboratory will love you. One other little trick I would say is, let's say you had a large gap here and you're not planning on putting clasping in there. Sometimes a little bit of ortho wax can help so that the impression material doesn't get locked in there and rip or whatever. But yeah, this is beautiful. So do this. You guys are like, for that easy, everybody be doing it. It says, do you still recommend taking an altered cast impression for any free end saddles during metal frame try-on for removable partial dentures? Um, I don't like myself altered cast impressions. The theory of it, I think, is good, but it becomes difficult to execute. And if the partial isn't perfectly seated on the model when the altered cast is poured, now I've all of a sudden changed the relationship between the tissue and the rest of the model. So I think it's a viable solution if you're worried about the accuracy in that area, but if you think the impression is good, I'd say go with it. I just feel like there's the chances of inducing inaccuracy are much greater than the chances of making things better. So this is pretty much an example of everything we want to avoid. You can see that here we don't have good adaptation to the tray, so this material isn't very well supported. We have the wash and the base are pretty well adapted, but it's weird how there's little wings of wash material. So you can assume this area is inaccurate, this area is inaccurate. We got these flow lines here. I can't tell for sure if this gets into a critical area or not. We may be able to stay above it. But unlike my other impression, that was exactly what you want to do. This is probably exactly what you want to avoid. Oh, okay. Thank you. All right. So, and you really got to look at all the places where the partial is going to contact: rests, guide planes, clasps, saddles. Um, so basically, do this, don't do this. Landmarks. I wanted to kind of go over this just as kind of a reminder, and then also to ask you sometimes to help out your laboratories. You guys have obviously much more training in anatomy and physiology than we do, and sometimes our technicians aren't as aware as you guys are. And I'll mention there's a specific example on the maxilla. So one of the things that can be really difficult to see on the model is the vibrating line. So if you take a nice marker of some kind and mark right where the vibrating line is, that'll help us. Now this is assuming that you capture it. So you got to capture the vibrating line, tuberosities, hamular notches, and the depth of the vestibule. Again, I know we can't border mold every time, but make sure that you let your laboratory know whether the impression is border molded or not. If it is, we'll want to extend all the way into the vestibule. Otherwise, we'll want to come up a little bit short. One of the things you can do to kind of evaluate is most laboratories, when they make the base plate for their bite block, they'll set the borders where they think the denture ought to be. So when you're looking at your base plate and you're like, oh, I think that's a little short, that's a good time to say, hey, I think we're missing this or that area. And then you can revalidate that when you do the try-in. Mandibular become even more important. We need to see the mylohyoid ridge because kind of one of our rules in dental laboratories, and again, you guys can check this when you put the base plates on, is that we don't want to extend into the retromylohyoid space because of all the mobile tissue down there. So do look very carefully at the extensions on your mandibular cases. And if you want, you could just trim them a little bit. Say, hey, I noticed a little overextension on the posterior left there. I trimmed it up a little bit. Please follow this for the final. Make sure you pick up that buccal shelf. As you guys know, that's where there's a great load bearing area there. So the broader we get on that, the more stable, relatively speaking, our mandibular denture is going to be. Anybody who knows me knows I love implants. So my solution for mandibular dentures is place some implants, but I know you can't always do that. And the retromolar pad areas. I know those are difficult to capture, but in the laboratory, especially for a double arch case, we're going to set the anterior aspect of the occlusal plane even with the incisal edges of 8 and 9. But the distal aspect is put halfway up the retromolar pads. So if we can't see the retromolar pads, makes it difficult to get a good setup. So picking that up is really good. Implant impressions. So let's talk about different techniques. So open tray. Again, today, the best way to take an implant impression is with a scan body and an intraoral scanner. But there are going to be some times when you want to or need to take an impression. So the first thing you want to keep in mind is that open tray impressions are always better than closed tray impressions. Why? Because with closed trays, you're taking the parts in and out, in and out. Every time you do that, you're not only stretching the impression material, but what if a little piece of material gets stuck down in there and the part doesn't seat all the way? However much that's off, that's the occlusion of your case. So if at all possible, you want to do an open tray technique. You know, you got to get an open tray component, put a hole in the tray, squirt your impression material. You'll need a cotton swab or something when it pokes through to make sure you clear the screw head. And then when you're taking your impression, try to inject all around the impression coping all the way down to the gingiva. Very, very, very important thing here. I almost forgot to mention. When you're taking your impression, once you've seated the impression coping, always take an x-ray. Because the biggest problem we see in laboratories, honestly, is either the wrong impression coping or not fully seated. Like if you eliminate those two problems, that's probably 85% of the implant problems we see in dental laboratories. So getting those right makes a huge difference. The other little thing that we sometimes see with this, which is kind of funny, is that we'll take the screw out and then we get the impression with the open tray coping in it, but it didn't come with the screw. If we don't have the screw, we can't put the analog on. Now, the reason that this is more accurate than closed tray is because this coping is locked in here forever. It can't come out. If for some reason an open tray coping tears out or something like that, take another impression. You can't seat it back in accurately. You won't get a good fit. And also do your laboratory a favor and make sure you write down what brand, line, and size of implant you have. So a Noble Active RP or something like that. Mostly the platform. One of the other things, a lot of implants now are platform shifted. And so, for instance, the old BioHorizon tapered internal 5.7, if it's a tapered plus and a 4.6, we don't need to know it's a 5.7 implant restoratively. We just need to know what the platform is. This may have been answered. I was actually going to do this in the next slide, but it says, does the lab prefer that we attach the coping to the analog and place it in the impression? If you have the analog, that would absolutely be great. What we do find a lot of times is that people will take a closed tray and put the impression coping back in without an analog. And that's really not good because now it's come out, it's gone back in, and then in the laboratory, we're going to have to take it out and put it back in again. So yeah, if you have an analog and you want to load it, that'd be great. If you don't have an analog, it's better just put it in a little box or baggie and send it along. Thank you very much. Good question. So closed tray impressions. Sometimes you're not going to be able to take a closed tray like this. Can't take a closed tray. This would get destroyed. Pulling this out, you'd need to do an open tray here. But if you want to do a closed tray, that's fine. If you're doing multiple sites, one thing you can do before you take the impression is etch the tooth number with a carbide high speed or something like that on the scan body, because that'll help us make sure we load them in the right position. You'll probably want to use a medium body impression material with your closed tray copings because you need it rigid enough to hold these in place, but you need it flexible enough to where it'll pull off without getting damaged. I always recommend whenever you're taking an impression for an implant case, try to inject all the way down around here, get this contact. We don't want to depend on the tray force to get the adaptation. We want to make sure that we pick up a nice, accurate registration by injecting the material and then, of course, load the tray. We need to have the impression coping that you took the impression with. So not a similar one, whatever. They can be slightly different. Maybe they get a little damaged or something like that. One of the things that's nice about analog impression copings is that if you have interference, you can grind on them. as long as we get it back in the same position and it doesn't compromise the ability to clock it, that can be fine, no problem. Feel free to do that. But do make sure that you send the open tray coping, or sorry, the closed tray coping and the screw. And as our one of our participants mentioned, if you have an analog and want to load it, that'd be great. Otherwise, your laboratory can load it. If the bite is way off or the crown is rotated with an open tray, probably the open tray coping wasn't engaged in the implant. There is a possibility for a closed tray to get loaded improperly in the laboratory. So if for some reason you need to do a redo, sometimes it's nice to send back the old impression, the new impression, label them, and ask your lab to reload it just to make sure there wasn't a loading problem. That can be kind of interesting. Bites. I find that especially with analog implant cases and large free ends, we tend to have problems with the bites. It's just, I mean, you look at this case, it would be very easy to get a millimeter or two of closure here without even thinking about it. So this is an example of a time when, even though you guys know now that I'm not a huge fan of closed trays, I would recommend a closed tray coping on this. Reason being that you can seat the closed tray copings, take your x-ray, and then put some bite material in there and take a nice bite like this. Then take the bite material out and take the impression with the copings in the exact same position. What's cool about that is your laboratory will already have the impression copings, so they can go ahead and pour the model and then use it to set the bite. This will really help with your free end cases. So if the bite's close and you can go over the healing abutments, good. But if you have a huge space like this, this can be a good little trick to use. Of course, I get to beat the drum for an iOS scanner. If you had just this tooth, if the person can bite accurately, you can get it. But I do find that bite registrations tend to be a little more challenging with implant cases. So putting a little more time into making sure you get a nice registration that you could actually use to articulate a case will make a big difference. Again, you'll notice my bites, they don't go up here. They're just in the area that we're working on. So both you and us can see that the teeth are interdigitating properly. Problems with implant impressions. Like I said, the biggest problem is this: components not seating. When I've been the troubleshooting person at the laboratory and I get a case back for an implant problem, the first thing I call the office to say, hey, can I see the x-ray for the impression coping? And if the answer is I don't have one, I'm thinking to myself, okay, I found the problem. So this is really, really important. You need to radiographically verify that the component's seated. You want to make sure that the component isn't being pushed off position by either another impression component or adjacent tooth or something like that. You want to make sure that the copings can seat fully and passively. Like we talked about, if the restoration looks twisted or it's way low in occlusion. Let's see. Yes, way low in occlusion. It probably was related to this. One other trick I would say is if you are using scan bodies, all my rules about adjusting for contacts and stuff don't apply. Scan bodies cannot be adjusted. If it gets nicked, cracked, whatever, it's no good. You got to replace it. So don't ever grind on a scan body, but you can grind on impression copings. Last thing is make sure you verify the components. I always recommend to offices get the report from the surgeon about the implant that was placed. And then when you order the parts, you can just say, hey, I have this lot number of implant and I need the components for it when you call the manufacturer. And that way you'll be sure you get the right thing. And then, of course, if you have that report and send it along to your laboratory, that'll help make sure that we get all the right parts, analog, the abutment, all that stuff, just to keep everything running smoothly. Full arch. If you're doing, so let's say you're partnering with a surgeon to do, and you're doing the pre-surgery impressions, two major things I would say with this. The first thing is take crown and bridge level impressions with denture border. So basically, you got to take impressions like you're doing a partial. If the surgeon's going to use guided components, the guided components sometimes fit to the teeth. So that needs to be really accurate. If we're doing digital workflows, we'll need to be able to align the files. So having a large file makes a difference. If you need a backup denture, you need a good enough impression to make an immediate denture. And especially with all on X, the whole ridge is nothing. It's no good for index. So a lot of times the borders are what we're using to actually index the case. And then the second thing you want to think about is bite. You will never have a better opportunity to adjust somebody's bite than the day you deliver all on X day of surgery provisional. So if the person is severely overclosed or not biting in CR, you really want to make sure you catch a nice CR bite at the correct VDO. And then the person will have the healing time where you can do equilibration and get them about where they need to be and then just fine tune it for the final restoration. If you're doing all on X, you always, always, always use an open tray impression. You'll be working to the MUAs by and large. Makes a huge difference, not just when you're working with the case initially, but during hygiene appointments and stuff like that. It may seem like you can save a little bit of money by going direct to fixture, but almost everybody who does that realizes, I should have saved the money a different way. It's just not good. Pay attention to your tray. Make sure that when you're punching the holes out that you don't weaken the tray too much. Other than that, it's a standard open tray impression. Sometimes you'll see people who want to build a verification jig, and you certainly can. I don't like doing analog all on X, but if you're doing it, you're going to have to do a bite block anyhow. So you may as well, don't waste your time. Just let your lab make your verification jig for you. And it'll save you a lot of time when you're taking that impression. Plus, your tray doesn't have to be so big to fit that big old verification jig in there. This is me beating the drum again for getting a nice CR bite at the correct VDO. For those of you that haven't seen a VDO gauge yet, I don't have a picture of it on this, but it'll change your life for full arch cases. It works by comparing this distance with this distance, and it'll give you a number you can put in a chart and check every time. So VDO gauge, look it up. It's super awesome. The other thing I wanted to mention before I finished up here today is that first appointment on all on X. Technically, it's not an impression appointment. We're talking about impressions, but this is the thing that's kind of weird. So you'll get a bite block back and a verification jig. One of the things I would recommend is that if you're doing an analog workflow, make sure you request a screw retain bite block for your all on X cases. The reason is that if it's a fixed case, it's going to need to have short borders. And if you have a screw retain bite block, you and the patient can start looking at the borders right from that very first appointment. Otherwise, you have something with denture borders, and then all of a sudden you get to the final and you're like, why does it have a shelf on here? Whereas you could have been dealing with that all along. So I strongly recommend, usually a screw retain will be like this. It'll engage a couple of the implants. The point of a verification jig is to ensure that the model and the mouth are the same. So your laboratory will fabricate this on the model, and what you want to do before you use it is put it on the model with one screw and make sure that it's fully seated on all the sites. We should do that, but if we didn't, that's not the best. Then you want to take it to the mouth and do the same thing. These days, they talk about doing a modified Sheffield test where you screw all of them down and then remove all but one random one, and it should seat passively. If it doesn't seat passively, cut both sides of the problematic implant, lute it all together with a low expansion resin, like something like GC pattern resin or something like that, and then protect it and send it back to your laboratory. I always say if it's one, cut it. If it's two, take a new impression, because you get to the point where you don't know which is good and which isn't. So help yourself out with that.